Doctor, we have to start.
Yes. First, I'd like to congratulate you all with this amazing conference. It is an amazing idea and really a good effort paid by all of you. I'd like to pay special thanks to Dr. Mohammed Shahid and Dr. Hela, my mentor. I'd like to thank her very much for this good opportunity to meet you all so we can share, which I hope to be a useful information for all of us.
Inshallah.
Thank you.
Thank you, Doctor. Good luck.
Thank you, inshallah. I wish you just give me a feedback about the presentation. Can you see it?
Okay, Doctor.
Yes, I can start now.
Okay.
Okay, our session for today, I hope, will answer this question. Oral mucositis in multiple etiologies, could it be targeted by single treatment? Welcome, everyone. Well, let us start to ask ourselves, what if? What if we can treat our patient by boosting his repair mechanism? What if we could offer our patient a pain relief depending on his own power to regenerate and repair without drug medication? What if we may transform the patient quality of life from this to this? If we may transform the patient oral mucositis from this to this in 24 hours. I'm talking about a reality here. This case I treated in the dermatology department, Asr Al-Aini. She had Stevens-Johnson syndrome. She was admitted at the dermatology inpatient clinic. Within 24 hours of treatment with platelet concentrate, these results for us all were amazing. Today's topic will include oral mucositis, the classical treatment, the alternative treatment, the new concept, and must ask it. Let's start by the definition. By definition, mucositis is the acute inflammatory response of the oral mucosa that may occur after cancer therapy, graft versus host disease due to drug toxicity or autoimmune diseases such as pemphigus vulgaris, benign mucous membrane pemphigoid, and Stevens-Johnson syndrome. This is what happens. You lose your epithelial cells layer by layer, then we reach loss of epithelium, expose the connective tissue, of course, a good media for bacteria to replicate, multiplicate, and give us inflammation and severe pain to the patient. We are talking about a common and painful condition. Who may suffer oral mucositis? Well, first of all, graft versus host disease. Hematopoietic stem cell transplantation have been associated with 60% chronic oral graft versus host disease mucositis, drug-induced, resembling from 6 up to 10% of some drugs, just like the anti-rheumatic drugs like methotrexate, for example. It is a common example of drug-induced toxicity and oral ulceration. Of course, you all know cancer treatment induced, whatever the cancer treatment, chemotherapy or radiotherapy, and autoimmune diseases. Comes on the top of the list, pemphigus vulgaris with 60% associated of oral lesion, benign mucous membrane pemphigoid, Stevens-Johnson syndrome, epidermolysis bullosa, and many others. Well, the WHO classified oral mucositis into grade 1, 2, 3, and 4 based on the symptoms of the patient. We find that grade 1 is just erythema. The patient is feeling a burning sensation. The grades will be from 1 to 3. Grade 2, ulcer, but the patient still able to eat solid food. Grade 3, ulcer requiring liquid diet. Grade 4, massive ulceration. As you can see, the patient cannot tolerate food at all. So let's have a look at the golden treatment for different cases of oral mucositis. How could we treat this mucositis? Well, corticosteroid is one common example. It is used as golden line of treatment in autoimmune diseases and in graft versus host disease, with 50% improvement in the patient's signs and symptoms in autoimmune disease and about 25% improvement in graft versus host disease. And do not forget, we have refractory patients with 0% improvement. The palliative treatment in cancer treatment induced mucositis. And here we are talking about zero improvement. It is a time-dependent healing mechanism. We are leaving the patient to heal on his own power. So the patient might suffer this mucositis up to 2 weeks without a single treatment. No treatment has proven to be effective in drug-induced oral mucositis toxicity. As we may review the literature, we will have that no treatment has been proven to be effective. So the only solution is to stop your drug medication, which caused the toxicity in the first place, to alter the dose, change it, and this might affect the systemic condition of the patient. This drug sometimes is the best result for him. What if we may replace these theories, targeting the disease pathogenic mechanism with a repair-targeted mechanism? Let's see. We are talking about corticosteroid. Corticosteroid suppress the immune response, acts by two ways, immediate and delayed. But at the end of the rule is corticosteroid will suppress the immune response. It targets the pathogenic mechanism behind the disease. This might take some time. Actually, in some diseases like pemphigus vulgaris, the patient may respond to systemic steroid and the skin lesion may improve, with the oral lesion remain for longer period of time, reaching up to 6 weeks in some cases. Can you imagine? 6 weeks, and this patient has pain. This patient cannot tolerate his food. Another mechanism of action, the platelet concentrate, sensing cells, targeting immune cells. Platelet can produce more than 14 growth factor. Tumor growth factor, platelet-derived growth factor, fibrogenic growth factor, insulin-like growth factor, and many others. It may remain active up to 14 days, secreting a huge amount of growth factors, boosting the repair mechanism, accelerating healing for this patient. As we said before, we are talking about the reality here. In 2012, Yolkanti et al. Demonstrated for the first time the management of oral mucositis in patients with graft versus disease using platelet lysate, one of the platelet concentrates with mucus paste applied to the patient's mucosa. This is the article. The patients who targeted were grade 3 and 4 mucositis. They were refractory to corticosteroid, and please observe this. We conducted research on methotrexate-induced mucositis in 2019, and another research on mucositis due to autoimmune. These are the two articles. We targeted grade 3 and grade 4 mucositis, and the results we reported were surprising for us as well. The corticosteroid has shown 50% improvement after 1 week of treatment. No, after 2 weeks. While the platelet group has given us 98% after 1 week of treatment, with the major response achieved in 3 days, just 3 days. Reviewing the literature, we may have many published articles We may have many published articles talking about the quantitative power of platelet concentrates. Many types of platelet concentrates are available. What type should we use? Injectable PRF, PRF, human platelet lysate, leukocytic PRP, leukocytic PRF. This is too much, isn't it? Well, it's all depending on you. We are seeing here normal plasma and platelet-rich plasma. This is what I'm targeting. I need to reach a platelet-rich concentrate. Whatever the technique for this concentrate you use, select the suitable one for you. Select what you find is easy to prepare. Take care of the consistency. You may produce a gel, plug, or serum-like material, liquid, whatever. Select what is suitable for you. It is all about the centrifugation cycle and the concentration of the platelet. Presence of leukocyte may offer some cytokines with growth factors. But in clinical application, there is no major differences between different types of platelet concentration. You may use the one you find it easy to prepare and simple for you. Mainly, keep it simple. We have two main types, the platelet-rich plasma and the platelet-rich fibrin. Today, I need to introduce the platelet lysate. What do you mean by platelet lysate? Well, platelet lysate is a platelet-rich plasma where we freeze the sample, then allow it to cool in room temperature, what we call thawing. We are aiming at breaking the cell membrane of the platelet to have all the growth factors without a platelet secretion. They are all ready, as if I'm using 14 different types of pure growth factors applied to the patient. This platelet lysate will offer me the opportunity to use plasmapheresis, to use donated blood. It should not be just autologous. It could be prepared from any plasmapheresis. Well, doing this, we must consider decontamination, standardization of our platelet lysate. And this, of course, could be done with the help of the pharmacologist. Now, as I said, select your platelet concentrate. Simple technique, desirable consistency, and ease of application. The available forms: liquid, lyophilized powder, and gel. This lyophilized powder has not been yet used for treatment. It is used as a scaffold for mesenchymal stem cell transplantation. But hopefully, we will reach this lyophilized powder working as a mattress that we can deliver to the patient, use as drug treatment.
افهم ازاي
هلغي الصوت
وشغليه على التاني
مش نازل البرنامج ده.
Well, obviously a problem. So can you hear me?
Sorry, doctor. No
How-
problem. No problem. Continue.
That's right. Now, hopefully, I can see one day this platelet lysate is working here in Egypt. We can use this form of platelet concentrate to treat cancer patients, as I have said before. We may have a difficulty limiting us from using the blood of the cancer-treated patients because they need no aid to their suffers. We cannot withdraw the blood. So we may have blood donated for them, prepare platelet lysate in a lyophilized powder, and start working with it. I think this will be an emerging topic for research in the few upcoming years. Well, any questions?
Doctor, if I have any question, I will present it for you.
Okay.
Okay.
Now, with the traditional anti-inflammatory treatment, we offer our patient a treatment for the underlying disease mechanism, but we offer his mucosa slow healing mucosal damage, prolonged pain, drug side effects, we all know, and a costly treatment, poor quality of life. Well, I'm talking about costly treatment because Kenalog now is for what, 95? The platelet concentrate treatment will offer our patient no treatment for the underlying disease mechanism. Well, we will leave this for the physician, but we offer his oral mucosa, an accelerated healing of the mucosal damage, rapid and more profound pain relief, no drug side effects, non-costly treatment, and definitely a better quality of life. Well, I have here some commonly asked questions. Let me answer it. The vehicle. Should I use oral base or what? Any mucoadhesive base will be all right. Mixing it with the gel, 1-to-1 is all right too. Mixing it with a cream base for 1-to-1 is all right too. Actually, many preparations have been produced. When we use a spray, buccal spraying gel have been introduced, patch, buccal patch, and many other available forms that could be mixed even with bone graft. We have been familiar with this in periodontology. How to mix? 1-to-1 is the percentage, and use the drug mixer or simply your spatula to mix it with oral base or gel. Standardization. We need to attain a platelet count for all our patients. The platelet count should not be less than sorry about the number, it is a mistake, 50,000 cells per cubic millimeter. For lysate, you may use plasmapheresis as I have demonstrated. Now, thank you all for attending this. And that will be all of it. I hope you enjoyed it.
Thank you, Dr. Eman. Really, it's more valuable and fruitful lecture and excellent presentation. It's a great pleasure to host you today in our first dental conference, DIDC 2020. Thank you, Dr. Eman.
Hello?
Hello?
أيوة.
Thanks, Dr. Eman, for really for such valuable and fruitful lecture and excellent presentation. Really, it's a great pleasure to host you today in our first dental conference, DIDC 2020. Thank you,
Well,
Dr.
no, thank you all so much. And again, I would like to thank my mentor, Dr. Hala, for this opportunity. Thank you all.
Thank you, Doctor. Dear guests and attendees, at the end of this session, I would like to thank my professor, first founder and first contributor in this great event, Professor Dr. Mohammed Shahat, and really I wish him success in what is coming. And I would like to thank Professor Dr. Hala Hazzaa, Professor Dr. Suzanne Ibrahim, Professor Dr. Nagla El-Kilani, and Professor Dr. Eman Magdy for such amazing lectures. And I would like to thank you for your kind attendance, and I hope we can live up to your expectations. Thank you very much.